Hello, dear colleagues. Today is Monday, but in Kazakhstan we have holidays. Tomorrow it would be the day of victory, so-called Victory Day from the Soviet period. And yesterday was also holiday. It's a Kazakh Men's Day. And we are working all days, all these holidays we are working. And now we are planning to do the case. I already shared the preparation patient with giant fusiform basilar aneurysm, which is 5 centimeter in length and 2.5 centimeter in diameter. And patient had symptoms of brain compression and was hospitalized to the stroke center. He has dizziness, vomiting, and it's a recommendation from our Turkish colleagues from Naci Koşer, Saruhan Çekirge, and the Turkish team. Before the placing any device in the basilar, we are expecting that would be brain edema and aneurysm thrombosis with the brain stem compression. That's why the first step of the operation we made a posterior fossa decompression with laminectomy делали сзади? Да. With laminectomy of C1 vertebra, posterior arch, and we did the eyebrow keyhole approach, and in our department for the subarachnoid hemorrhage and other occlusive hydrocephalus, we start to do cisternostomy, and you can see there is a metal on right eyebrow region. It was done cisternostomy and some pneumocephalus I will show you later on CT. And patient already had a coronary bypass for coronary artery stenosis and infarct. Infarct myocarda был? For the myocardial infarction. And he is hypertensive. On the table at the beginning of the operation the blood pressure was 180 and now 151. Yes, we did some preparation, and I hope patient and we are lucky. We checked all PCOMs. There is no PCOM. I will show here. We did 4-vessel angiography. This is a basilar aneurysm, and there is no PCOM. Slight atherosclerosis on the cavernous ICA. And on the left side also some atherosclerosis here and here, but no PCOM. And vertebral artery is coming from the aortic arch, you can see here. And the main vertebral is the left, but in this case anterior spinal artery is coming from right side. I asked Sheikh Ahmed to do angiography selectively from the vertebral. The first was from the subclavian. This is a anterior spinal artery. That's why we will start to do stenting from right vertebral to distal basilar. Maybe we'll place additional stent to the PCA territory. We'll see. And this part bit stenotic. Maybe at the end of operation we will do angioplasty. This is 10 units. Okay. This one. Okay. 2.5, nearly 3 millimeter. Distal basilar is nearly 3.5 millimeter. Not 4 millimeter. I took a Vasco 25. It came from box of Leo Plus. The first Leo Plus would be 4.5 and 75 in length. But так, сезос наш назва, да? Жо, на нашу керек. Баскасын саласың. Баскасын қайтадан саласыңыз. Стентін маған наш бересіңіз. The problem is when we open the Leo 4.575, the delivery wire will be very distal. That's why I will try to open it from basilar, distal basilar, and I hope it will not jump inside the aneurysm. Okay, and delivery wire could be very distal. That's why it might be a little bit challenging. Okay. Okay. The guiding is Neuromax. I expected to have distal access catheter inside the Neuromax, but we'll try to do without distal access. Distal access could be ACE catheter from Penumbra, but now we will see. Казр. Да, сделайте что-нибудь. Накорми двоечный. Yes, and we are working under local anesthesia. If there is some technical problem, we will switch for the general. If I will take ACE catheter, then my Vasco would be very short. It would be technically challenging. Ксифаком. Вот. Okay, I'm inside the basilar. Now I will try to go with my Neuromax. Now it's okay. it would be some spasm. Heparin, we already gave to patient 5,000 units of heparin. That's why I can block the vertebral artery. No problem. We have a second vertebral. It's all the time challenging. For me, it was a question to start from proximal to distal or from distal to proximal, antegrade stenting or retrograde stenting. But now we will see how it would be better. Okay, I need to control the қозғалмай жата беріңіз. There is quite enough distance in a distal basilar. We can start to stand from the level of SCA and then go down. Okay, smart mask. Один раз назад. Smart mask. Ала берсін. Okay. Не болды аға? You need to keep in mind that this is a fusiform aneurysm and there is a lot of room for the instrument. Maybe I will go to the left. Yes, it's easier. Yes, I need to be inside the PCA because the delivery wire will be 7 centimeters at the end of the stent delivery. Maybe we can cut the delivery wire, but I'm not sure. It would be helpful. Just a second. It's very rare aneurysms, but all the time it's challenging. Okay, the stent looks like this. Да, итер. Итер, қатты итер керек. It needs some force when you push the stent. It's a very long stent. I think it's the longest stent available in the market. Итер. Okay, now it's better. Итер. Дозатормен гепарин қосып қоя салшы. 1000 единица в час до конца. Қозғалмай жата беріңіз аға. Қазір стентіңізді аша бастаймыз. Yes, the patient under local anesthesia, that's why we can speak with the patient. Okay. It's okay. as the easiest way to place flow diverter stent, but then it would be very, very thrombogenic, and FD in such a case is more risky. And that's why the telescopic Leos first choice. It's very hard to push. Ne oldu aga? Okay, we'll start here. You see, it's not so stable. May jump. And you see the delivery wire is going forward. It's jumping. Yes, but we can go distally if it's necessary. I will start from the vertebral PCA, okay? Then we will need to place one more stent in the PCA. Now stent inside the puzzler. Вперед. Okay, let's try to go inside. Yes, the stent is detached. It might be a problem. I compressed the stent. It's usually a problem to go inside. We need to take the second microcatheter and use the second microcatheter. Вперед. I will try to go, but it's touching the stent. Now I'm inside the... okay. Okay. Now we're inside the bezel area. Бақыт 4,5-25 ашып бере салшы. Stand. Okay. I will deliver the second stand, 4.525. And then see. Okay. Ашыр. Yes. Stretch. İtirir. Bakın. Yes, there is one more option when we can place two FDs in the Leo Plus in parallel, but it would be I'm not sure that it's possible to do here in Almaty. Okay, now can delivery wire is out of the out of the stand, but we know that the stand, one stand is inside the other. Okay. Бахт, не ашпеш гамма что-нибудь такое. Семнадцатое. Гамма емес, хотя гамма шир. Yes, for the stabilization, I will use gamma. We'll go distally, and it would be helpful. Так, во вторую нужно будет включить еще одну систему. Yeah. Kasna. Time to time we speak in Kazakh with our team and some Russian words. Mm-hmm. Okay. It's okay. I will put inside. Okay. You can take out the torquer. I will do little j for the headway, for the Chikai, to do navigation easier. There is another option. We can leave like this and without any closing the contralateral vertebral. I think it's also okay. But yes, but usually it might be a bit risky to leave the second vertebral. That's why I will go I think I'm inside the stand, yeah? Step like I'm inside the stand. Okay. This I did to have access inside the stand if something will happen. This is for security reason. We'll leave it like this. Okay. Okay. It's better to have after the longest stand we have is a 5.575, or we can place another two 4.520. Okay, 4.520, it's a 15 and measure the abrever. 15, 18, 33, it would be 33. Let's measure the distance. Okay. Okay, let's measure the distance. One stand we have here, it's nearly half centimeter. And now we need another couple of stands. It would be 5 centimeter. If we will take 5.5, then then 5.5 would be here. Or we can place two 4.5 25 and 4.5 20. I think it would be better. We can place another couple of stands in a month if it's needed. Okay. I will take out the Chikai. Nisam kik spirasar. Plastic. Okay. Бақыт, ана жерде 4,5-25 деген бар ғой. Соны бере салыңыз. The next stand would be 4.525. Yes, it's also possible to place the flow diverter in a mid-basilar segment, but we need to be sure that patient would be okay. That's why I don't want to take additional risk. Okay. This is inside, this is outside.
Давление переизмерьте, пожалуйста.
It's outside. This part, it goes outside. Okay, I need to give a bigger curve. Okay, Nina, пересажь. Пластмассовый кизер. Sheikh Ahmed and Yalalta is helping me, assisting me on this case. And I think they also couldn't understand what's happening. Yeah? Yalalta, do you understand what's happening? Maybe a little bit, yeah? Давление пока что. It looks like there is a PC пайка on this territory. Okay, it's outside of the stand. Torker. There is a пайка. Okay, we have one more option. We can finish here before placing any additional device. We have already two stands inside. Okay, just a second. But it looks okay. Бақытма не бересаш? Дайнап қойсаш, чекай блектағы біреу. Пока ашпай тұрады. Жоқ, дайнап қойсың. Пока ашпай тұрады. Is it inside or outside?
Seems like inside.
Looks like inside, yeah? The catheter is touching the stent. Okay. It's touching the stent.
Гепарин поставили?
Гепарин, да.
Общий гепарин 5000, 10 тысяч был, да?
This happened because Vasco has a pear-shaped tip. That's why during the delivery it's like this. Oh, now it's okay. Now it's okay. We are at the distal portion of the stent. I think I will overlap at the level of stent conjunction. I will overlap the third stand at the level of 2 stands to create more stable construct. Okay, push it. İttir. İttir. İttir in English would be push. Push it.
Böyle alçısını sürekli akasın.
Alınca. Okay. Sheikh Ahmed suggests me to comment only in English. But time to time I like to speak in Kazakh. It's my native language. That's why it's better to communicate inside the operating room in Kazakh language. Yes, but this is streaming, that's why Sheikh Ahmed may be correct. I think nearly here. Macaroni is coming. I will pull a little bit. Now it's opening. I will pull a little bit. I think from this point is better. Now is overlapping.
Phone zones.
Stand to another. I have 3 stands in the proximal part. I think it's not detached. Yes, it's not detached. Just a second. When the Leo is not detached, there is a maneuver. We need to take a torque here and torque, half torque right, half torque left, half right, half left, half right, half left, 10 times. Then it's detaching. It's not detached. Stand is not detached. On lateral, I am looking on lateral. It's a problem. Yeah, now it's detached. But I'm not inside the stand. I'm touching one of the side of the stand. Okay. Let's take it out and let's go. Okay, AP. It's between the stands, yeah?
Mhm.
It's not like between the stands. Now I'm touching the proximal stand. I hope I'm inside, yes. Yes, I'm inside the stand. Then we can place stand number 4. You know why this happened? Because the gamma is in between two stands. I will take out the gamma. Now it should be better. There is the spasm. Су тасып қалмасына байланды. Tamam. Hadi korktum. As there is a spasm. At the proximal part we have 3 stands and one more 4.520 4.20 да? Так, анау 28 бен кіреді ол да? Мынаны бері салшы. 4.20. I asked for the stand number 4. It would be 4.520. Yes. Yes. This is a very complex disease and the treatment is also complex. From the beginning of the first stent, placing the first stent, we already spent 26 minutes. Kazakh thrombot test classical is 15 minutes. And disaggregation in this patient is okay. Yes, no problem with disaggregation. But anticoagulation we gave at the beginning of the procedure, just after placement of introducer sheath. We gave 5,000 units of heparin, and now for the second dose we asked for another 1,000 units every hour. We put on compressor, and now we have 1,000 every hour. I will little bit overlap here, and distal basilar would be with 1 stent. You see? Okay. Now it's better. I'm finishing with stenting and гамма. Надо будет в гамму положить чекай. Maybe we will take. It's too easy. 4 stents. Okay. Okay. Ананың несін аласыр? Y коннекторын. Ана катетердің Y коннекторын маған жылғай сал. Да, бақыт. Бірдеме айттыңыз ба? Okay. Doshan made one more control of verified aggregometry. Now we will know how much the... Yeah, соның несін аласың. Doshan, қанша болып тұр? Okay. The stents are okay. There is a bit spasm, but it's okay. I hope the proximal part will not fish mouse, and now we can go to the left vertebral. And before I will do hijama. I will take out my guiding. Okay. Нем koyasır. Столды жылыстырыш, Шахмет. Былай қарай жылыстыр. Итер, катетер көру керек. Now is okay. Now I'm outside of the system. Lan төгесің. Тут тастайсың. I made a hijama, and now I will do angio from brachiocephalic trunk. Okay, I need to go to the 35.
Дальше. Ну, чуть-чуть лучше.
Қанша көрсетті?
Қанша? 152 и 45. 150.
Ну, vertebral.
45%.
Проводник сутыш.
А?
Проводник сутыш. I think the guiding is fell down. That's why it's happening like this. Aşağıdan bir koptum ya.
Чуть-чуть ажарно. Районда.
Okay, from here it's okay. This introducer's not hydrophilic, that's why there is a lot of friction. Yes, now it's better. The flow inside the aneurysm became slow. Тағы бір 5000 гепарин болюсына жібере салсыншы.
Болюсно.
I'm asking for additional 5000 unit heparin intravenously by bolus because the flow is getting slower.
Дос қанша ішеді? Кім аратан өлі ішеді? Олар келеді олар.
I need to keep in mind the vertebral is coming from the aortic arch. This is problem of this. Ah, jeez. This is carotid. Ощущение.
Болды, қазір.
It's also cleaning. This is the right side. So clearly. Ronopper. It's also cleaning. In French language, it would be merda. Merda. Merda. Merda means putana. It's not going where I want to go. It goes to the subclavian. Okay, I will ask Sheikh Ahmed to do this because he made it at the first attempt. Maybe we will change the guiding. Okay. Не бере саш? Hyperion шестерка бере саш?
Давайте нам не корыстать.
It's okay. It's okay. There's a lot of friction inside.
Yeah.
It's okay. I changed the guiding for 6 French coronary Hyperion from Asahi. Dr. Maimon says Asahi. Asahi. It's nice guiding. Then it would be more comfortable. Was it? Kapı system. Yes, I little bit straightened the right coronary, and now it's MPC, multipurpose. Надо капать. Вперед. Капай. Хорошо. Басқасын бере салшы. Тұра тұр. Острады. А полный метхон. Аж қойсы. Азыц. Это... Да, Джавасон. Нет, это другое. Ана босап қалған бір система тұрған ауыстырып саласыз ба? Ана қолындағы система тартылып отыр. It's a left carotid, and now catheter will go to the vertebral. Yes, it's look like this. This is the vertebral artery.
Монитор жасайды.
Еш нәрсе ма? Okay. Ничего. Местный остров, слышь? Система. Она новый имбирь, слышь? Бос шотран. Она бос шотран шейтин. Она уже. Если он берется. Она еще есть. Еще есть. Как-то актроешься. Так, ну. Вот это, да? Тоже нормально, да, смотри. Гамма. Мгм. Smart mask. Now we will occlude the left vertebral artery. Just below the basilar at the level of stenosis. Nowadays, more and more procedures we do under local anesthesia. This is one of the examples of the local anesthesia. And thanks to advanced technique in meningioma embolization, in dural access, and thanks to cerebral stenosis intracranial, we start to do more and more local anesthesia cases. Okay. Okay. Спираль. 30. Вестивом без кастратор. 6-26 келесер. The first coil would be 626 Cosmos Ashir. I hope there is no spinal arteries at this segment, but there is a pica. You can see pica is coming here. Here is the pica. We need to coil just this segment before the pica. The pica is very small. Yalalta, you can. Yalalta adresu. Можете мы ставим перфекцию. Yes, push. Вот, да. Есть же видео. Есть же видео. А пациент пережил видео снимать? Для себя? В конце, хорошо? Не сейчас. Okay, smart mask. Stop. Smart mask. Mhm. The coil size is 6 by 26. Okay. I think the lower part of the coil mass is just near the pica. I need to replace this mass. Now it's better. Қалайсыз? Атыңыз кім? Хорошо. It's above. Бақыт 4-10 не бере салшы, Optima. Now it would be 4x10 Optima coil. Okay, push it. It's a Gambatar technique. Thank you, Gambatar. Üçte 6, 3'te 8 ne var? Bakın. 3'te 6, 3'te 8 ne var? 3'te 8, 3'te 8 helical. Aha, microflex. O son spiral. Patient already on heparin and the coil will thrombose and will occlude. Dexamethasone, Onica, 12 milligram. Then we will continue dexamethasone tomorrow, 8 for 5 days, and then 4 milligram for a week. Maybe patient would be on tablets of dexamethasone, 2 milligram from discharge till 1 month, maybe. We'll see. There is a marker.
Yeah.
That's why I'm pushing without control. But it's controlled by the manufacturer. I think it's enough. We don't need to create a black dot from coils. It will thrombose. Okay. We gave 12 milligram of dexamethasone to patient, and now I will do control angio. Then maybe we will go to the right side and we'll do another control. Okay, patient is moving. Қозғалмаңыз. There is a big stagnation inside the aneurysm. Okay. Проиграй. Play it, бассаш. With the stent everything is okay. Бассаш. Вперед. Вперед. Okay. With the artery also everything is okay. I will pull back guiding. Now I will do one more control and then we will finish. Yes, there is a stagnation inside the aneurysm. Pica is fine. Yeah. Okay. Okay, now we will take out we took out the guiding, and you can see the shape of the guiding. It was the Judkins Wright 4.0. Now it's a multi-purpose like Chaperon, but it's more stiffer than Chaperon, but this point is a bit softer. Okay, let's do control CT and finish. Thank you. Let's wait for the control CT.
И справа контроль.
I have seen the vertebral artery, the right vertebral. It's already in place. The vertebral right is in place. Okay, let's wait for the control CT. And then we will finish. It's a long Monday. I'm flying to Kizlarda city. Today is birthday of my teacher. Пока не свети. Концентратор, бір секунд. Все, Шахмет, можешь светить. Окей. Мы ждем, Наталья. Сейчас контрольник это сделает. On the screen. Okay. This is distal part of the stand and the aneurysm with the contrast. This is a coil mass and the proximal part. This is after decompression, posterior fossa, after resection of C1. This is C1, this is occipital bone. Everything is clear, stent is okay, the PCA territory, and there is a pneumocephaly after membrane Liljequist perforation. Marat has a good experience of keyhole eyebrow approach. He did approach from here, and he went to the basal cisterns and then perforated the membrane Liljequist. In our hospital we have no endoscopes for triventriculostomy. That's why we modified the technique, and we do it by microsurgery from this approach, and it's very helpful, and there is no need to perforate the brain tissue, and it's all subarachnoidal. And also the decompression as recommended by Turkish team, and I hope patient will be okay, and we will share follow-up images in 3, 6 and 12 months. I hope so. I hope so patient will be stable.
We will write some article.
Okay. Have a good day. Have a good Monday. In United States also it's a Monday. In Canada. And have a good Monday, have a good working week, and we have holidays, and tomorrow would be Victory Day, and it's one more weekend for us. Thank you for watching, thank you for sharing our time in CATLab. See you very soon in somewhere. Have a good day. Bye bye.